I'd like to introduce the members of the panel and the facilitator. The facilitator is Joel Benware. He's the Vice President of Information Systems at Northwestern Medical Center. He's got 2 MAs and a BA, and here's where some of the alphabet soup comes into play. He's a member of CHC, CPIMS, ACHE, and CHIME. And if you know what they mean, $1 goes to the winner by the end of the session. Joel has significant experience as a CTO and CIO. And this is Joel Benward to my right. The next person next to Joel is Dev Culver. He's Executive Director and CEO of Maine Health Infonet. All the hospitals in Maine are connected to Infonet, and there are 400 practices connected. He's got a couple acronyms. He's worked prior to Maine Health Infonet at Cerner and Eclipsys, and some of his initials are CCHIT, AHIMA, and NEHIMSS, which I know is pronounced NEHIMS. That's the only one I know. Charlie Hewitt from, sorry, let me do Mike Gagnon, next to Dev. You're supposed to sit down in this order. Michael Gagnon is the CTO at VITL. He's a senior IT professional with over 30 years of experience doing infrastructure and systems implementation. He's got experience at least 2 health information exchanges, one in Wisconsin and one in Michigan. Next is Charlie Hewitt. Go back and forth. Charlie Hewitt is the director of the Health Information Exchange at RIQI, RIQI, which is the Rhode Island Quality Institute. Is that correct? Mm-hmm. Thank you. RIQI has 70 data sharing partners, and he's got experience in healthcare, government work, and interestingly, aerospace. Charlie has a BA and an MBA from Harvard. Next is Dr. Denise Hine, Executive Director of the GAHIN, which I know stands for Georgia HIN. She's a national expert in health information exchanges in states. She's managed outreach for more than 5,200 providers and 56 critical access hospitals. So the work that she's done is about 2 Vermonts included. And then at the end is Joel Reba. Joel is this Chief Operating Officer of HIXNY, which is Health Information Exchange of New York. He's got a Bachelor of Science and an MBA, and he's got 20 years of experience in senior IT leadership. So at this point, I'll turn this over to Joel Benware, who will then facilitate the panel discussions.
Great, thank you, Sandy. When we were putting this panel discussion together, I was working with Rob Gibson and a few other folks from VITL, and I said, well, how many people are we expecting for this conversation? And the definitive answer was somewhere between 0 and 250. So thank you. I actually started counting heads, and I think we actually hit the average on that. So we're just a little over 100, I think, if I counted properly, and a few people snuck in there. So we hit the average. Unfortunately, if it was more than 10, if it was less than 10, we were going to have this in the bar downstairs. So we kind of blew that opportunity. So we'll have to wait for 2 more hours, and we'll socialize there. But thank you all for coming. How we're going to kick things off today is go through this distinctive panel here and let each member give you a background information on each one of their HIEs. And then from there, please write down any questions you have or thoughts about their presentations, and we'll start a pretty lively discussion and hopefully a roast of a few of these guys up here as well. So with that, I'll hand it over to Dev.
Good afternoon. There's always a risky thing when you offer somebody 7 to 10 minutes, so beware. Also, I'm afraid we were just joking about this up on the dais. If you didn't go to Evelyn Wood's speed reading course, don't worry, the slides will be available later on. So I'm going to take you through a very, very quick review of Health Infonet, look at its current operations, some of the value-added services, focusing on quite frankly, analytics, which is something we've gotten into fairly deeply in the last year. Talk a little bit about some of our grant activity, two grants in particular, and also where we're heading. We were asked also to highlight some of the challenges, and I think probably a few folks will be nodding your head because I won't put three up there. And if any of them are a surprise to you, we're in trouble. So let me quickly introduce you to Health Infonet. Health Infonet is a not-for-profit 501c3, was formed in 2006 officially as a corporation, but the effort really started in 2004. We operate the statewide exchange. We also carry the designation of the designated statewide health information exchange via a governor's executive order, which is kind of weird if you think about it. A governor putting a private company in executive order is kind of an unusual thing. But we have had a fairly extensive experience as the federal programs are run by. We were both the primary contractor for the ONC eHealth Collaborative, and we were also the holder of the grant for the Regional Extension Center. We were also in two of the other major grants, one of them being one of the Beacon grants. We, as I said, have a fairly long history. This is actually our 10th year, if you don't count incorporation in 2006. So we've been at this a little while. I came on in 2006, but I give a lot of the credit to what was the foundation to our organization coming forward in 2004 and 2005, particularly starting the trust framework, and we can come back and talk about trust frameworks a little bit. We have a fairly robust data set today, and this continues to grow as we get wrapped up in different projects, different initiatives. For example, we started out only with primary diagnosis. Now we have primary and secondary because we needed that for some of the analytic work that was being done in the Beacon project. As was indicated, we have 37 hospitals in the state of Maine, acute care hospitals. They're all under contract, and all but 3 of them are actually physically connected bidirectionally. The other 3 have view, and they're working on getting connected by the end of this year. Maine is not unlike a lot of New England states in that 80% of the physicians work for a hospital or a large group practice. So when you get the hospitals and large group practices, you tend to get the physicians. We have about 80% of the primary care marketplace connected to us today. The specialists, not so much, about 20% of the market there. We are actually running an organization that at this point in time can sustain the basic exchange services on just the subscriptions that come from the provider community. And that's really important. As you know, as a not-for-profit, your money comes from grants as far as investment and development, and you have to live off of what you can raise in terms of the marketplace. We've had a fairly successful year or two in the last, and right now I can tell you that the basic exchange services are sustainable in the state of Maine, which is a nice place to be, quite frankly. Some stats on us. Right now in the database, we have about 1.3 million lives. Now, Maine is only 1.3 lives. So it's not that we have everybody in the state of Maine. We have about 90% of the residents in the state of Maine have something in the exchange, some of it a lot more extensive than others, perhaps. We are an opt-out consent model state and have been since our outset, and our opt-out rate runs about 1.2%, which I think if you start talking to exchanges who are opt-outs around the country, that's within the range of what folks tend to be in terms of that type of a consent model. On any given month, about 50% of our authorized users are accessing patients. This is something I want to highlight. You can read through the detail at your leisure here, but this last 12 months, we exchanged over 3.4 million records. And that's through a whole host of different things, whether it was through portal structure or communication through the ACO structures we work in, and also connection to public health. 3.4 million records is a substantial push in terms of what goes on. We have a variety of services that go beyond the basic exchange. They incorporate things like supporting our client base with meaningful use. We also have some fairly significant connections to the ACO marketplace in Maine. We are their primary data supplier, and that's near real time, meaning that both this time it's ADT and lab. That information is in their hands within about a minute and a half or 2 after we receive it. So it's pretty important in terms of real-time notification. That whole service of notification, I'm sure others will talk about it too, has taken off with a vengeance and is growing rapidly in terms of the numbers of notifications at any given month. We also serve as a resource for organizations that have multiple patient identifiers and want one enterprise identifier. We serve back to these institutions a single master patient index identifier that they then use to coordinate information as far as a profile across their organization. We also have been into a bunch of analytics, and that's what I wanted to spend a couple of minutes on. About 2 years ago, we started a project with a small group out of Stanford University in Palo Alto, California. And the focus was to see whether a tool that they had built to predict variation in the genome could be applied to medical information. And so basically we spent a year figuring out what our data needed to be in terms of cleaning it up. When you're serving in an exchange, what you're trying to do is make sure a lab result or a discharge summary is available. You don't pay a lot of attention to the quality of some of the other data like admission source and discharge disposition, all that stuff. People don't really care in the context of what a portal-based exchange is. When you start doing analytics, those things matter a lot. And so after a year's worth of time and effort working to clean the data up, we began running some analytics. A couple of things are really fun. Right now, we're out servicing. We have 4 contracts in place today, and we'll have a number more over the next few months. But right now, the folks who are connected to us can see a picture of the activity across the state in terms of volume and market share that's a month old. And we do that because even though the data in the warehouse is actually a day old, politically that was untenable because I could sit there and watch my competitor across town on a day-by-day basis. So we decided to make it a month. Hey, you never realize how political this adventure is until you get in the middle of it. And it's really political. So right now, this is starting to be used very heavily when folks are asking questions. Gee, I wonder where we should place another clinic, or I wonder where we. So it's really fun. We have a statewide database that's been around a number of years in Maine, but it's 2 years old, and now these guys are starting to see data that's a month old in terms of market share and volume. We also have gotten into these predictors. There are now 6 predictors that are out there. Who's going to show up in the emergency room in the next 6 months? Who's going to get admitted in the next 6 months? Who's going to be in the top 10% of expensive patients in the next 6 months? Who's going to be readmitted, which I'll come back to in a minute, which is really fun, in the next 30 days, and who's going to return to the emergency room in the next 30 days. We've just now started vetting a series of disease-based predictors, so now we're working with AMI, stroke, and type 2 diabetes. It's really been an interesting ride. We've had the opportunity to go out and clinically vet these. It scares the heck out of clinical people because these are not evidence-based, these are pattern-based. So this is what happens when you get a large database and you start to have correlation between points of convergence that lead to something. We've done extremely well in terms of the predictability of things happening, and we're finding both ACO and, quite frankly, care management in the context of hospitals, for example, that are trying to manage free care and Medicaid patients more effectively, being able to see prediction on them out into the future is very powerful. I'll be more than happy to talk some more about this. The data is a day old. Think about that. The data that's driving the models is a day old. So a clinical event that occurred yesterday is being incorporated into the prediction of risk today, plus you're getting the community-wide view of that. Which is really quite powerful. The neat thing about the 30-day readmission is every morning the facilities that are using it run the patients that are in their beds. So before the patient ever gets out of the bed, they already know what kind of a risk they're going to face with that person, and that causes them to think perhaps differently about how they manage discharge planning. We are involved in 2 major grants right now. We are one of the 5 states, or 6 I guess it was now, that got a SIM grant, and we have 6 very specific deliverables in that. You can read that, or I'm not going to read it to you because my time is rapidly shrinking away here, but thankfully our deliverables are pretty specific. Oops, excuse me. Oop, that went too far. Our deliverables are pretty specific. I seem to be going the wrong direction. Yeah, hold on, F5. Okay, you get to see it all over again. All right, bear with me. I will try not to push too many buttons too fast here. And they involve some heavy connection to behavioral health. I know Rhode Island's going to talk a little bit about their work around behavioral and substance abuse. Very important developments and work in that area. When we get to the panel discussion, we can have a lot of conversation about engaging patients. Unfortunately, Health Infonet's been down the road now 3 times involved in defining and starting to bring forward patient portals. And each time little funny things have happened. One of them was called meaningful use. Stage 2 kind of screwed things up pretty badly for us. So we're going back at it again now, but through a provider, which will be an interesting project. The other thing, using that analytic structure I was telling you about, we're starting to build a dashboard for Maine Care, which is our Medicaid program. So they will have the analytics and the predictors for their membership, which will be extremely important in a state that has exceptionally high emergency room usage out of its Medicaid population. Engaging and figuring out who's heading in the wrong direction early will be very important. The other major grant is a grant that HRSA issued, and we're now Sean just told me, my COO sitting up here, just told me this morning that we received our second year funding notice as it was proposed as a 3-year program to connect the VA to our statewide exchange. I'm proud to announce that we are also now certified by Healthy Way. We got there before our vendor did, long story. That's something else we need to talk a little bit about too in the discussion sessions. And finally, this effort really is fun because you get to understand that there's the national VA and the local VA, and the two of them aren't necessarily aligned with each other in terms of priority objectives, but it's a really good thing. Maine has the 5th highest percentage of residents who are vets in the country, and that's one of the reasons we ended up with the grant. Where are we headed? Well, we're working on a 5-year strategic plan, which will be brought forward. Clearly, we're focusing on what comes next. The basic exchange for us is a loss leader. By itself, we can just break even. Well, breaking even is death over time, so that's not good enough. And so basically, we're going to come out of this plan with a bunch of new and hopefully very effective directions that will focus on business development and revenue. We also, quite frankly, will continue to build out the analytical reporting structure. It's proving to be very, very valuable and very much in demand when people finally get to it. We will continue to focus on the specialty and non-hospital sectors. We have representation from every sector, long-term care, home health, et cetera, in the structure today, but not deep enough yet. And so those particular sectors need to be brought in. And I think, quite frankly, workflow optimization will continue to be a major focus for us. It's still an impediment, even though it takes 11 seconds to go find your patient, it's still an impediment. And so the next step there is probably heading into middleware and becoming ubiquitous and stop how you come to a portal at all. So 3 challenges, and then I'll turn it over to Mike. Number 1, clearly, I don't know what's going on in your state, but we sure are having some fun. Consolidation like crazy. We're seeing all our independent hospitals are going away. We're going to be very quickly to the point where we have 2 major systems and maybe 1 or 2 floaters on the outside. That causes some very interesting disruption. It also causes some question of what are you doing exchange? Why do we need you at all? And I think we're positioned well to answer that question. But I do think in our delivery structure, as with yours, keeping that trust framework alive, keeping the willingness to share information openly and without reservation is a major challenge. And this is only getting harder. It's not getting easier. I would say the ACO has started to regenerate some of those ugly old days of I'm going to hold on to my information and not let you see it type things. So that's a major trend. Secondly, there's no question the data standards keep changing. It's a bit of a pain. We started at a very stable place called HL7, and now we're finding out that that's not necessarily the basic standard that we're going to be moving forward with CDA, et cetera, coming forward. But it's been a very effective standard, particularly when you're dealing with large institutions. Finally, I think the meaningful use standards and other similar government-based incentive programs in some cases have done more damage than good in terms of the health exchange world. Particularly, I would argue here that the ideology that became direct kind of blinded everybody to what the real goal was, which is to have true interoperability. And those of us who actually are query-based and delivering quite a substantial set of data are actually being punished in terms of not being recognized. We are currently working a legislative process at the federal level with one of our senators, actually we now have both senators on board, trying to convince CMS to provide a way that truly a query-based exchange can meet that continuity of care requirement without having to put the providers through a whole bunch of craziness. So we can come back and talk more. The portal thing is another great example of great policy thinking without actual practicality behind it. They hadn't realized that the impact on the patient was now you've got 7 portals. Aren't you lucky? That's not very patient-friendly. And so I think that's something we need to come back and spend some time on. So with that, Michael, I'm going to turn this over to you.
All right, thank you. It's going to feel a little bit like, one thing after another, and you're going to get so much information, you're going to go, okay, now what do I ask? So I'm going to do an overview of the VHI, or the Vermont Health Information Exchange, which is the state network here. Just quickly, VITL was formed in 2005 from the Vermont Association of Hospitals and Health Systems. It's a not-for-profit. We now have a staff of 34, grown quite a bit in the last 2 years. We offices in Burlington, Montpelier, 12-member board, and we also are the designated state health information exchange, even though we are a private corporation. We were the rec while that program was still in place and retain all of that staff and still do some great work there, and are kind of transitioning that staff into more of a customer support role. And we have been selected as kind of the HIE infrastructure for the ACOs in the state, and there are 3 of them in the state. And so they recognized that they weren't probably going to be able to easily get that data without having an infrastructure in place to do that, and it was a costly proposition to try to put that in place without their health information exchange. We have 16 hospitals, 13 of the 14 of them are in Vermont, over 140 medical practices and several other healthcare organizations participating, home health, nursing homes, et cetera, spreading our way, and we do about 4 million messages a month at this point. A large percentage of those are admission, discharge, transfer, patient demographic kind of messages, but lots and lots of labs and lots of increasing number of continuity of care documents and consolidated CDAs, which are care summaries. Well, that was in the wrong place. That's supposed to be the end slide. So this is kind of where we are with the hospital interface status right now. Don't know how readable that is from the back, but we're doing quite well with many of the interfaces. Medication history will kind of go live all at once, pretty much, because it's a feed from a medication site that we get to, and as soon as you turn on VITL access, you get that. So even though we show a lot of blue there, all of those will go green almost, kind of simultaneously. We have lots of interfaces, and this is the dog work of health information exchange, is just slogging through vendor after vendor and interface and practice after practice, and just getting the data and taking whatever you can get, pretty much. And so it amounts to ADT, which is admission, discharge, transfer, so it's patient demographics, and it's events like the patient was in my office, or the patient was in the emergency department, or in the hospital. Transcribed reports, labs, as I said, CCDs, and we're doing quite a few immunizations and passing them on to the state. So we're helping our organizations with meaningful use by passing immunizations on to the Vermont Department of Health. The core capabilities are like many others: master patient index, record locator service, which is really just an index of all the documents in your network, and clinical data repositories. And our network is set up as each organization having its own clinical data repository separate from one another. They aren't in the community, they aren't spread all out. They're co-located, but they're not commingled, is the way we like to say it. VITL Direct is our direct protocol, and I'll agree with what the folks at Maine said, that Direct kind of set us back a little bit. If you're a query-based exchange, or we're just about to be, or if you're in an organization that's been pushing CCDs to organizations for a long time, like we are, it was not really a positive move, because it's kind of go sideways with this. And so I think we'll hear differently, at least when I met the new ONC recently, Karen DeSalvo. I think they're going to be moving in a slightly different direction. I don't think Direct is going away, but I think that they're going to be more open to query-based exchanges. So I think we'll hear some positive things tomorrow. And we've been doing ACO gateways, which are really a filter on our patients to say, what's the beneficiary population for this ACO, and how do we send just that data to the ACOs? And so we built this filtering mechanism into our network so that we can pretty much filter by any population of patients. And so it's a kind of generic capability, but helps meet the needs of the accountable care organizations in the state. We will just briefly talk about consent, and when we get to the question and answer period, we're going to limit how many questions. Really? I've gone down this hole many times. I'm sure everyone in this group has gone down this consent thing, and it's just it's a very complex topic, and not one that one we can talk about forever and probably never get to the right answer. But we are a global opt-in state, meaning everyone is out until they opt in. We were opt-in by organization. That has recently been changed by the Green Mountain Care Board, and we think that generally is a positive, but not everybody thinks that. And we will have to work out how we're going to do cross-community. And the first cross-community major effort we're going to do is actually with Joel's organization over in Hicksney. They are kind of our western boundary of New York neighbor, and there's a lot of patients that cross over that boundary. And so we have kind of started to work together about how we're going to make that work. I will not go through this whole diagram. There's a lot of things connected and growing is what I want to say with this, and you can certainly catch me at another time if you want to go through that. Some of the planned services we have, you will hear about that a lot these 2 days about how we're just rolling out VITL Access, which is our provider portal, and I won't steal anyone's thunder from that one, but we plan to add next year imaging to that portal. We just recently heard that we won a grant from the RSNA to add imaging to VITL Access, and so we're pretty excited about that. That starts next year. People of our own group didn't even know that. We're getting cheers from our own group, yep. So that we're pretty excited about that. We're going to add event notification at the request of the accountable care organizations to the network, which is someone shows up in the ED, we can tell the providers that that person showed up in the emergency department, or you get referred for specialist care, perhaps that, but any kind of events to be notified on. We are early on in the jumping into analytics, really kind of starting with, just as Maine did, with data quality first, kind of collecting the data into a warehouse and thinking about working on the data quality, and that will take us a while, and we anticipate a year easily. And so I'm happy to hear that, we're not way off from that. Healthy waste certification is kind of important to us because it would make VITL Access more useful, because then transitions of care could count through query mechanisms. So sorry if that's confusing, but right now kind of one of the only ways we have to let the transitions of care meaningful use work is through direct. And if we had healthy waste certification, they could look them up in VITL Access, and that would count as a transitions of care. So that's important to us for that reason, not to mention that it could help us in terms of connections to other HIEs in the country. And then we're delving into thinking about a patient portal. And again, the same kind of, I call it the over-portalization issue is that, yeah, sure, I got 7 portals I got to look into. I got 7 doctors now, I mean, it's not really a patient-centric approach that we took there. It's kind of good that patients get this data in their hands and they can do the view, down, and load and transmit their care summaries, but not if you have to go to 4 or 5 or 6 different places to do it. Joel's been a big advocate of moving in this direction with us. So what's special or unique about us? Well, first, one thing about how we're funded. A unique thing that happened in this state is they formed, we won't call it a tax on claims that allowed there to be state matching funds for federal funds, which allowed us to be funded. And so that's been in place for quite some time, 2002? 7 years. 7 years. We started with CCD interfaces a lot earlier than a lot of people. That's another interesting, and we needed them because we were feeding information to the Vermont Blueprint for Health, and that requires more robust data than you get in just ADTs and labs. And so we started with CCDs early, and you can see battle scars on lots of people in our staff from that. It's not been an easy trudge, although it's getting a little easier as we go forward. So like I've said, Blueprint for Health, we've been doing that for many years. The ACO gateways are an interesting project in that we're able to filter data and effectively send data from our network out to another organization that's going to do their own analytics on that. And we're just about to jump into doing our data warehouse with a company called SAS. So that's kind of a little bit special and unique. What's our coolest project? I think that this one of combining clinical and claims data together to start to be able to do analytics will be the coolest project we start to work on. We have co-bid with OnPoint out of Maine to be the all-payer claims database. We've not won that bid yet. But if we do, we would provide the master patient index for all, not only patients, but all beneficiaries in the state. So we'd have all the insurance members and all the patients in one master patient index, which would then be, like, if you know anything about this, how these HIE things happen, the very first thing you need to do is figure out what patient is across each set of data. And if we were able to do that, that'll be the first first ability to match across those two data sets, and then perhaps start to do some matching of actual clinical and claims data. So not only what's going on with a patient from a clinical perspective, but also kind of what it's costing them to do that. And so we're excited about that, even in its early phases. What are our core challenges? We need to move from state funding to other sources of income. And we've made some significant progress in that this year, and we need to make significantly more. EHR vendor systems interoperability continues to be a hot button for us. There are, it's a real challenge. We think when you meet Dr. DeSalvo, she's moving in the right direction in this regard, I think, and moving into that arena. New document types beyond what I call the CCDA, Consolidated CDA, or care summaries. The care summary is a good document. It has good information in it, but it's just not robust enough for things like nursing home transfers or transfers to specialists, or for that matter, anything other than what it was really originally designed for, which is a primary care doc doing a referral to someone else. I mean, it's a nice core data set, but this has to get a lot better. And there's a group called Health Story that are working on 5 or 6 or 7 other document types that would be standardized into EHRs for various different scenarios. And so I think that's an important one. Sustainability. We're talking about some kind of utility model and maybe private subscriptions. I don't know where that's going yet, but we need to find out how to keep ourselves sustainable going forward that isn't always grant funding. And we need to continue to work on our data quality. So that's it. I'm going to introduce Charlie from Current Care and Rhode Island Quality Institute.
Yeah, right. I'll end up in the back there. Good afternoon. I'm Charlie Hewitt. I'm my formal title is Director of HIE Product Delivery, which means that I guess I'm the guy that gets stuck with actually building this stuff, or at least planning it and so forth. The Rhode Island Quality Institute is a 501c3 corporation in Rhode Island. We are the state designated entity. We are the developers and owners of what's called Current Care, which is the health information exchange. It's a repository type exchange. That is the software that it's based on is the InterSystems Health Share product, and we are a very close partner with InterSystems. We help basically define what the product is. That goes back a number of years now, and we work with them very closely in determining what's coming next. What do I do? Just hit there we go. That's a good one. So this presentation was actually built more towards providers to sell them on adopting the services that we offer, and it's actually it's in the process of being adopted. We have about 1,000 physicians out of maybe a total population of 3,000 PCPs in Rhode Island that they and their staffs have been trained on the use of the provider portal. And We are also offering various flavors of notification. We'll talk about that a little bit further. It's particularly important as we go into the future with ACOs. So right now we are collecting med history, lab results, imaging reports, the ADTs, admission, discharge, transfers, a lot of data that comes into current care. Current care is an opt-in model, opt-in to send. We can't even see the data until you give us permission to collect your data, and then also permission to disclose it. When you sign up for current care, you tell us who we can share the data with. Most folks select all of my treating providers. That makes it easy. Some select only in an emergency. That's about 2%. All my treating providers is about 96%. And then the remainder are those that select just these named providers. And they give us the provider, and then we have the problem of figuring out who does that provider belong to. And that'll take us into the provider directory piece that we're working on right now. But through that, we offer two kinds of service to providers. There are the alerts, which are basically notification service. So if you are admitted to a emergency room, we learn that from the ADT transaction that we receive, and we can route that transaction to the primary care physician or anyone else that has subscribed to you. The viewer is the provider portal, and as we use the viewer, we are finding out from the feedback from the marketplace that the viewer that was designed for, say, PCPs is not a particularly useful viewer to provide to an emergency room physician. And so now we're looking at how do we easily configure that viewer to the role of the person who is actually using that. That's kind of a future thing. But I should mention today we have about 40% of the state is opted into current care. That number increases at the rate of about 8,000 to 9,000 a month as new people sign up. We sure would like to get to a tipping point where people sign themselves up, but I will tell you that that is a very tough slog to get people to opt into current care. That's the bad news. The good news is that when they do opt into current care, we are able to share data through the HIE that comes from places like substance abuse treatment. We can get into the detail of how that's done if you're interested. But one of the things that makes Rhode Island a rather unique place, thanks to this opt-in model, is that we can collect data from an organization that's subject to 42 CFR Part 2. We can collect that data and then share it outbound to whoever the person has said we can share it with. Telehealth alerts. We are working actually with a couple of visiting nurse association where they have monitors out in the home, and when something unusual happens and they detect that, they can trigger an alert manually. The reason it's manual is that a lot of the information they get is not terribly reliable. For instance, they might have a weight scale at home and a painter comes over and puts a 10-gallon bucket of paint on top of the weight scale. Of course, the thing goes off the charts, everybody gets confused, and it takes a human being in the loop to make the decision as to whether or not that's a bona fide alert. This is, it was through this service, in fact, that we came up with the idea of subscribing a patient, where a physician might be a cardiologist. They certainly wouldn't show up on an ADT transaction, but that cardiologist can subscribe to the patient, and when we get an alert on that patient, we not only notify the PCP, but we notify the cardiologist or a whole care team. A hospital alert basically is a direct message with a note on it. You can't read this. but it's just test data anyway. But basically, it's a direct message that says so-and-so is in the hospital, and if you want more information, here's a link to the viewer to have a look at what's going on with the patient. There's very limited information in the alert itself. The viewer itself is what you'd expect. You log on and you get access to patient information, pretty traditional kind of stuff. I won't walk through all these slides. There's a lot of information in there, obviously. We have, as I mentioned, about 40% of Rhode Islanders are enrolled, getting about 8,000 a month. We have posted about 25 million transactions to the database since its inception. We started collecting data in April of 2011, and it's just accumulating over time. We have over 70 data sharing partners now. That's all of the acute care hospitals in Rhode Island except the VA and the Department of Defense. And we have quite a few of the commercial labs. We have nearly all of the pharmacies feeding data through SureScripts and then on to us. And we have about 40 individual practices that send us CCDs when their EHR locks an encounter. The EHR automatically sends us a CCD to tell us about that encounter. We took a survey of the providers that are using current care, and I won't go through the details in this, but the bottom line is that those that use it are finding great value out of it. The real trick is to get them to use it, to get it incorporated in their workflow. My personal opinion is that the REC, which is part of the Rhode Island Quality Institute, we also have the REC group with us. They are going to play a very vital role in not only making people aware of what an EHR is, which is what the REC's first mission was, but now to go back there and help them understand how to make use of these services, the viewer and the alerts, and also continue to work with the vendors to do things like bi-directional interaction with current care, so that within an EHR session you can get right to the patient in current care without having to log on separately and all that sort of thing. So this was basically, we have doctors that says they love us, and which is true. There are actually the patient-centered medical home. There is a very large movement in Rhode Island to get to patient-centered medical home. It isn't the doc so much, it's the nurse care managers that really, really, really like using the current care service. As to challenges in the future, you've heard about a bunch of them. One of the things we're working on now is a provider directory which is intended to become the authoritative source for provider information in Rhode Island. First, for things like the insurance exchange. We're working very closely with them. So the provider directory will not only tell you that Dr. Jones is a cardiologist that practices at this address and has these phone numbers and stuff like that, but also what healthcare plans Dr. Jones participates in, where Dr. Jones practices, has admitting privileges at Rhode Island Hospital, and so on and so forth. Building that directory is a bear of a project. That's the bad news. If you try it, talk to me. But if you have it, there's a huge market for that. I can't tell you how many people in Rhode Island must be maintaining a provider directory, but it's got to be a big number, because every time we talk to a hospital, an ACO, a agency of the government, there's a bunch of them that are interested in this, and also even the insurance companies. People are these institutions, this is all non-mission critical stuff in the sense you're not providing any value to anybody other than yourself, but you're spending a lot of money on So this is a really significant project that we've been working on now for actually a couple of years. And in fact, our technology partner has identified it as a strategic initiative and is very happy that we really basically beat them up and said, you need to do this with us. Other projects, I mentioned that we're an opt-in, and that's an impediment. Because we're an opt-in, if an ACO wants to be notified about, say they have a group of CHF patients, if they use current care for the notification, they're only going to get notified about 40% of that panel. What they need is 100%. And so what we're in the process of doing, and we're pretty far down this road, is basically alongside of current care, we'll leverage the underlying infrastructure, but creating contract relationships with ACOs. There's two big ones in Rhode Island already, and there's another one coming along. And those ACOs will subscribe their patients. They will opt their patients to not to current care, but to RIQI. And through that mechanism, we can offer a fee-based service to the ACOs based on lists that are 100%, both current care patients and non-current care patients. We've done a lot of work on the legal side to make sure we can do this. The good news is we can. We have some agreements that we have to get with the various hospitals to allow us to collect their information. But the reception to this idea has been terrific. We have been criticized for years because we're an opt-in, and the answer is if we're doing this with patients who are not involved, obviously we can't do things like collect Part 2 data, substance abuse treatment, but we can do a lot of other things that fall within the law, within HIPAA. I've probably taken more time than I'm allowed, so I better get off the podium and move off to the next. Denise?
All right, well, good afternoon and greetings from the South. What a pleasure to be here, particularly because it's been over 90 degrees every day in Georgia, so it's nice to get a break from the heat. So I am from Georgia, Georgia Health Information Network, and we affectionately call it GHIN. A little bit about GHIN. We are the nonprofit organization and the statewide health information exchange network. The way our model was formed is our Georgia Department of Community Health received the funding from the Office of the National Coordinator to start the statewide health information exchange. And the vision was always to move the exchange functionality over to a nonprofit organization. That has officially happened, and we're finishing up our first year. So I get to be the baby of the group, but I'm particularly proud of our progress, and I feel pretty good sitting here because I'm thinking I'm dealing with the same challenges these veterans have, so I'm pretty good here. So we're here to close the patient information gap. I won't spend time on that. I know everyone knows what we're doing here. Our motto is network of networks, and what that means is we're heavily reliant upon the large health systems and the regional health information exchanges to connect to our network. And for example, if we have a large health system, let's say our largest health system brings about 1,000 providers when they connect. That means for GHIN, our team, we do one connection to a health system, but that means we have thousands of providers connected. So for us, that helps us keep the operations costs low. So that's why we call it a network of networks. And every model has its challenges. I don't have a team that goes out to, we don't have boots on the ground that's going out to physician practices and doing connections. We rely on those health systems and regional health information exchanges to do the downstream connections. So that's how we are modeled. We have taken advantage of federal funding from our Department of Community Health, and we rely on, or we did rely heavily on our department to help us with complex issues such as consent and sensitive health information. Those are probably the toughest topics that we've all had to tackle. So we were able to leverage much of the funding and the support from our state agency at the time. So our providers have 3 ways to get connected to Georgia. They either connect directly, and that's going to be our large health systems or our regional health information exchanges. A provider, a downstream provider, would connect through a networked health information exchange. And then the third way we're exploring, which became highly political, is that we would connect vendors. Then that way, for example, I'll just use, I'll use Greenway, for example, Georgia-based company. Let's say, we made one connection with Greenway. Greenway could open up the pipeline to all of their clients. Well, our regional health information exchanges said, no, you're competing with us now. We want to be able to offer the connection to the statewide health information exchange. So the option is still here. We're still exploring that with some particular vendors, but we haven't taken that off the table. But it has been highly debated and became very political for us. So we offer 2 products and services, and all of them are catered to make sure our providers can meet the meaningful use requirements around secure direct exchange, query-based exchange, or the consumer-mediated exchange. So our 2 products, Georgia Direct, which is our secure, simple, direct exchange, and then Georgia Connected Care, which is our query-based, robust system. So with Georgia Direct, Georgia was the early adopter for Georgia Direct. So we have over 2,800 registered providers right now. And we have 2 specialized projects, one around dialysis. So we have about 10 dialysis centers connected around using exchange with Direct. And then we have an asthma project. This was through our Department of Public Health and our Department of Community Health. And we have particular providers working with a special population around asthma. And if you're not familiar with XDR, we have about 20 hospitals in Georgia using our XDR connection. And what that means is we offer the direct functionality, we integrate it into their electronic health record. So these organizations have electronic health records, but they choose, either they don't have the direct protocol, or they choose not to have to pay the fees with their vendor because we don't charge our providers at all for our products. So we have 20 organizations right now, and I can tell you we get 2 to 3 calls a day for Direct. We have small hospitals on it, large hospitals, long-term care facilities, and even employee health clinics using Direct. A nice use case is one of our largest health systems. Many of our long-term care facilities do not have robust EHRs, and they have charged us with getting all of our long-term care facilities in Georgia using Direct so that they can exchange information. We are also part of the Direct Trust Bundle, and what that means is when our providers, there's 2,800 providers, sign up for Direct, they get a georgiadirect.net address. And before we joined the Trust Bundle, when they looked in their address book, the provider directory had everyone in there that had a georgiadirect.net address. Now, because we're part of the Direct Trust Bundle, everybody in the Trust Bundle can now be accessed through our georgiadirect.net. So they now have access to all providers nationally who are part of this Direct Trust Bundle. So we are very proud of that, and I'm really excited that we can offer that feature for our providers in Georgia. So our next product is Georgia Connected Care, and it's the query-based exchange, and I heard the comments about direct versus query-based, and I definitely agree with that. So with our query-based product, our members have access to Medicaid, health, pharmacy, and dental data. We loaded 3 years' worth of claims into the system. They have access to immunization information, and I know you guys see the words GRITS on the screen. That is the official name of our immunization system in Georgia. So they will receive information, but they can also submit, and so bi-directional immunization submission is available as well. We offer a web-based clinical portal for our Medicaid and also many of our state agencies who did not have the robust EHRs. We offer the clinical viewer with single sign-on. So our users, for example, our public health users who use a system called Shines, they go right into Shines and they have access to the clinical viewer to view information. We are part of the national network, Healthy Way, and I'm going to make a claim here. We did go live, and we went live with South Carolina as our first exchange, and we are claiming with South Carolina that we are the first state HIE to state HIE connection. So until someone tells me different, I'm going to keep saying that. And then we're also working on event notification services, as many of my peers have described, not only for payers, which is where I started, and now transitioned over to starting with provider first, those alerts, and working on those now. And then adding additional registries. Our members have access to the immunization registry, but we're also adding the tumor registry, cancer registry, Alzheimer's registry, and other registries to help them meet the meaningful use requirements. So anticipated features, and these will be the features that we will charge for as well. So we won't charge for our basic connection, but we are looking to start charging for our new features that we're working on. These advanced care alerts would be not only the event notifications, but also patient condition notifications, such as elevated blood pressure or abnormal lab results, PHR information, analytics, as many of my peers have described. We're now working on vendor-neutral medical imaging exchange. So I'm in the process of looking for vendor-neutral vendor to help me connect all of these exchanges. I know. Also working on, my members told me they want lab results. So I'm working on that as well. And then support for long-term care, which I described. It looks like we're going to have to start with direct for our long-term care facilities. We're connecting our state agency with behavioral health, and then also specialty pharmacy. Our members told us they want to see medication information, medication fill information. So I'm going to be talking to people like SureScripts and Relay Health and a few other vendors to see if they will connect with us. So who's connected in Georgia? We have many of our state agencies connected. Our Medicaid agency is connected. So our Medicaid providers have access to view information through our Medicaid managed care information system. We also have public health connected. They provide us information on immunization, but they're also working on several use cases with us, which is where we want to go with many of our state agencies. What we're doing with public health is they now have access to the clinical viewer. So if a provider calls public health or reports a patient with a reportable disease, public health can now look in the clinical viewer and gather clinical information on that patient instead of waiting on the medical record with phone calls, waiting on that information from our providers. The phases of the use case go all the way up to GHIN becoming the source of information for HIV and other chronic diseases, working with public health. So it's a really nice use case that's in different phases, with all the way to providing alerts to different providers on patients who have not picked up their medication or did not show up for appointments. So we are working on that use case with public health right now. DFACS, which is our Department of Family and Children's Services, they have access to the clinical viewer through their single sign-on through their system. Of course, they care for children, so as children who are, if a child is admitted into a hospital, they can see their clinical information. Defects will be a great use case that we're working on right now for the alerts. Could you imagine if you're a case manager and you received an alert that one of your children is in the hospital rather than waiting to be told weeks later? So we're working on that use case. And then our Department of Juvenile Justice, who also works with children, has access to our clinical viewer. We have a payer who is a part of our care management organization with our Medicaid agency who has access to a clinical viewer, mainly though for our foster children. Emory Healthcare, which is our largest academic hospital, is live, and I believe I'm making another claim here. We are the first Cerner to Epic connection nationally. We also have Grady Health System, which is our largest public hospital in the state. We have our largest children's hospital going live this month, actually next week. And then the Georgia Health Connect, which is our regional extension center, they formed a health information exchange. They're going live in October. With these groups connected, we have over 15 million patients in our MPI right now, and thousands of physicians who have access to our system right now. So our state agency, our Department of Behavioral Health, and is planning for kickoff this month. With that, we've had to review our member agreement. We've talked a little bit about sensitive health information, and now we're adding Part 2 information to our network. So we may have to revise our member agreement that took me about 4 months to put together and negotiate with our members. So I'm like, no, we can't touch the member agreement. But we do need to have some additional protections in place for Part 2. And some of these organizations you may not recognize, but these are some of our regional health information exchanges, Gracie and West Georgia. We also have a robust telehealth network in the state of Georgia that spreads not only through Georgia, but in some of the southeast region as well. They are going live next year, starting first quarter of next year. Our Georgia Association for Primary Health Care is our organization who will connect our federally qualified health centers. And then the next two organizations, Archie, Healthy Connection, those are also regional health information exchanges. And then Alabama One Health Record is another state HIE that we will connect to through the through Healthy Way. We actually started with Alabama, but then they needed to do some other connections first, so we're just waiting on a phone call for them to tell us they're ready to get started again. So engaged. Oh, I got 2 minutes. Okay, engaged. I know you can't see this list, so let me. Payers keep me up at night because they are part of my sustainability plan, strategic plan. Providers don't like them so much. So scared of the clinical information, scared of sharing it with payers. Florida, Tennessee, North Carolina are organizations or other states we're looking to connect to. We're trying to connect all of our bordering states. Also, federal agencies, VA and SSA, we've been having weekly calls with them to get started through the National Exchange. Rite Aid is a specialty pharmacy that is very interested in joining our network. And many of these are some of our other large health systems across the state. It's important that you know that GHIN, we don't store any clinical data. We just move it. We have an MPI, but we do not store our any clinical data. And then our sources of revenue. Right now, we are heavily reliant upon our state agency to pass through the federal funding to support us. I mentioned payers. My goal right now is to get a payer connected starting in October. You didn't see them queued up though, did you? So I'm not doing so well with that. Payers will pay. And then we're looking into grants and private donations. And then our providers will pay for those advanced products and services. And this is just a diagram that shows you all the different types of organizations we hope to have connected. And those locks and keys, those locks there means that we're going to be moving information securely. All right, so that's an overview, and I'm going to turn it back over. I was gonna let him come by. It's only room for one back there.
Hello, I'm Joel Reba from Hicksney. Hicksney, as many of you know, is the other side of the lake. So we have a mirror image of Vermont, goes from the Capital District area of Albany, Schenectady, Troy, our urban center, all the way up to the Canadian border. About the size of Vermont, has about 1.5 million people. It's a census population. Our HIE has about a little over 2 million people in it, of course, because we cross border a little bit, and we also have people obviously born and die and all that type of thing. So we have a very robust HIE. I stopped counting CCDs being exchanged about 10 million. Our clinical transactions passed $1 billion a long time ago. I just don't even count them anymore. It just becomes numbers at some point. I'm not going to talk to you about a lot of technology, I hope. The first word is architecture. It sounds like an IT thing maybe. It is, but it should be the business level of IT, so I'm going to hope to stay out of the technology except for maybe 1 or 2 slides towards the end where we talk about how we actually do things. So today I'm going to introduce the business view of what we do, which is collaboration. We really focus on this being a platform for collaboration, how it differs from developing any other types of IT systems. That's why we do what we do level of the architecture. Then we drill down into the process, and that's really is what we do. And then we get a little bit, let's a couple of slides where I promise to stay away from it, is how we do it. Okay, and it gets into the technology a bit, but I'll try to only hit the pieces that are real key to being successful. So drivers of the social network, which is what this is. This is our Facebook for sharing your health information between your providers and insurance plans, et cetera. And the goal is to achieve the triple aim. I'm sure that should be everyone's goal who's involved in HIE, and probably is. I look at it a little deeper than that, and I look at the patient experience portion of it and try to focus on the patient engaging the healthcare system as one system, so that when they go from one provider to another, it should be the same experience as if you were, say, on the West Coast at a Kaiser or an oriented area where you would go to a Kaiser doctor or Kaiser emergency room, et cetera, and theoretically they're all in the same system in the data flows. In our disconnected world of Hicksney, where we have 600 plus physicians connected through about 30 different EMRs, we have 25 hospitals connected. Our goal is to achieve that same level of patient experience. We have a patient portal where the patient's able to connect to the community record rather than connecting individually to those 7 different places they go if they go to 7 different places. So the patient experience is that I engaged healthcare. And who that person gets their paycheck from who treated me really shouldn't be important to that person who's getting healthcare at that moment. So getting into collaboration, what do you have to do to make that happen? Well, you have to answer the question, what's in it for me? A whole lot, right? This is what we do mainly. In the typical model of healthcare, paying for procedures model of healthcare, honestly, when a physician tells us, I don't get paid to do that, they're right, and I actually agree with them, right? So if you're not getting paid for this added cost, especially when we charge them money, we run a business at Hicksney. We send out bills. So, this bill may be the difference between that doctor's son being able to go to summer camp or not. So if he's running his own small practice. So the fact is, being able to answer what's in it for me and actually get a payback for those physicians is extremely important. So we focus on the benefits for the business that they're going to get in more efficiency. The main payback at the end of the day for all of this is the changing payment model. So we are fortunate, very fortunate, in the upstate New York area that we had several initiatives that moved towards payment reform. So we still have a large multi-payer medical home in the northern part of the region, just the other side of the lake. We have a capital district-centered, patient-centered medical home. We have several other ACOs emerging. So we take each one of those programs as they come along, and we kind of glom onto it. Right? So this is our sustainability model: is find anything that can force people to really need information to do their job, and to do it in a better way, and latch ourselves onto that model. So we have, the various CMS programs are, they're popular in the region. And if you have a higher reimbursement rate for doing a follow-up on a patient who just got discharged from the ED, well, you're going to need that alert or notification to know that they just got discharged from the ED. And so that's one of the things that it's HIEs, you heard about discharge, alerts and notifications a lot up here. It's one of the few things that a centralized HIE can do that nobody else can do, right? So you have surveillance on the patient on every single transaction that's happening in order to be able to do those alerts and do it with the assured factor that you hit it, not that you were relying on somebody to code the data right, but I know it's that person. They put in that someone else was their PCP, but I know this is their care coordinator over here because they subscribe to the patient, so you're able to do that. So I'll get off that slide because I spent all day there. So I got it a little bit into the rewarding. I think, most businesses run on either consciously or subconsciously on the cost of quality equation. And, this equation basically says that total cost of quality is the cost of compliance plus the cost of non-compliance. Well, what we want people to comply with is using information to treat patients. And we have to make it so that the cost of non-compliance goes up, and that's what payment reform is about. And the cost of compliance goes down, which is a matter of doing your HIE efficiently and bringing costs down to do it so that the cost per patient becomes minimal. So we focus heavily on, both getting a payback for our customers, and as I talk about this, you realize I approach this very much as a business, not as, I don't talk about grants, I'm talking about how we generate revenue for what we do. And we bring in, we focus very much on a payback for our customers and being able to articulate that for them exactly what it is. And so that it actually goes down to the bottom line, hard dollars, not other theoretical things. So you want to do this in a viral method. The fact is, there's a cost to doing exchange, and you have to make it easy to do. If you're building Facebook, Facebook has to be really hard, and you have to have the information that the other guy wants, right? So getting the right information in exchange, very important, because if I'm not interested in what you have out there, I'm not going to do it. I'm not going to friend you on Facebook if I'm not interested in your family's pictures. So the fact is, you have to have a strong information base to support it, and that's a lot about this. We have physicians who use HIE. We have physicians who tell their patients about HIE. We've had HIV patients in the hospital being asked questions by physicians. The patient lifts up off his oxygen mask and tells the doctor that his information is in HIE. And because the FQHE goes to, they let him know that. And so the next time he was in the emergency room up the street, he was able to tell him. So, and that hospital does have access, and so they went and they got it from HIE. And so we have a lot of stories like that. And really the physician support of going around and saying, no, this is the way I deliver information. You want my information, that's where you join, that's where you're going to get it. That's the number one driver of HIE success at the end of the day. So what do we do, actually? What we do is, everybody does the same thing. It's real simple. We run an electronic file room and electronic mail room at the end of the day. So we are on a consent to access model. Not opt in, not opt out. It's consent to access basically means in paper world, patient would come to your office, they would sign a release that you would present to other practices to say, this patient has said it's okay for you to release this data to me, send it over. Now, of course, it takes a lot of work out of that, just get them to sign it, record it in the system, everybody trusts that it's recorded in the system, it's valid, and the data flows. So in order to perform that function, we have operated as a file room for everybody. Everybody sends in all their data. Substance use, mental health, everything. Because we're a business associate of theirs for storing their information for the purpose of sharing potentially in the future. And that's the same as putting the data into your EMR legally, from a legal standpoint. So no difference. You just have an electronic file room. You're putting your data in. The mailroom option says, oh, there's some data I'm going to send in that, hey, I want to pump over to somebody else. I want to send a lab result to this person. I want to send an image study to that person. I'll label it this way, set a business rule with you that says when you get that, file it in the file room, but also mail it to whoever. And then we do a combination of those two services for the surveillance, the alerts, notifications, where our way our surveillance works for us, because we're consent to access, is that someone has collected consent to access, and therefore they can set that subscription on that patient that says, even though I'm not indicated on the message, I want a copy of any data or data of this type, and this type. They come in on this patient. So that may be the reason not indicated is there's a care manager or someone like that that the treating physician doesn't know about. And they are able to then set that consent that they collected on the patient and set a subscription that says, send me this. We do it in bulk, they don't have to do it on a patient by patient basis. Sure, very similar. So, the consent model is very key to what you're doing. We don't do the opt-in, opt-out. We like that model. But I could see, the same sort of business process could work in other models as well. The one-to-one messaging doesn't require any consent, obviously. That's a determined message from the sender that determines they're going to send a one-to-one, like either over direct or lab results delivery, those types of things. And the surveillance, of course, is, as I earlier just explained. And the way we implemented this is where I'll get a little technical, but if you need, I'll kind of go as fast as I can unless you want to hear more about it. But we got we use a services-oriented architecture. We enter a lot of abstraction into the system in order to make this happen. So therefore, the idea is that you don't have to talk the same talk as the person you're trying to receive the information from. They send the data in one way, you consume it another. Magic happens in between. That's what happens in our system. You have two levels of interoperability, one where we're changing that form of the data. That's what they call syntactical interoperability, so you can hear what I'm saying. And to a limited degree, we do semantic interoperability. We'll actually change code sets, et cetera. We do less of that today. We'll probably have to do more in the future. And so that means, obviously, someone's talking in the phone in French, and you want to hear it in English. You might need some interpreter in between. We're real close to Canadian border, so that might happen a lot. So, the enterprise service bus is the platform for, so it's the operating system of a services-oriented architecture. So you want to build up on a strong enterprise service bus. What's important about this slide is really off that software factory off to the side. So we're building this software factory. It allows us to do all these alerts, notifications, et cetera. Also allows us to do custom business rules. And as we move more into the ACO marketplace emerging, what we look at is that the state HIEs, and to some degree a Hicksney falling under there somewhere, you fall into this world of paving the roads. And so we paved the roads for HIE. That's the state's job, right? They pave the highways. They're paving, a lot of states are paving the HIE roads. And above that, you need this idea of perhaps a virtual private exchange that can run on those roads. Not that you have to run somewhere else and duplicate the spend on that infrastructure. And this is actually quite a debate going on in our state. I have a debate on this at national levels. It's a problem that needs to be solved for. Because in your ACO or your payer network, et cetera, you have proprietary relationships that allow you to exchange data today, perfectly legal by legacy means or perhaps electronically. The minute you step into the HIE space, you shouldn't lose that capability, right? More importantly, you should be able to automate that capability. So if you have a proprietary network, you should be able to have those people in your proprietary network by which you have contracts by which you're able to share patient data and share that data equally, right? So that's a personal charge for me. It's like my personal passion is working on this virtual private HIE network across various states as well as nationally. And the success that we've had in the end is like I've told you the numbers of what we've connected and we move, and you know it's more about to me trying to get the patient to have that experience of I'm engaging healthcare. We have answered what's in it for me for our community, and we have 70% penetration in all segments of the healthcare market. The remaining market, a lot of them don't even have systems, so there isn't too much left for us to actually do except for make sure people get long-term care, et cetera, and get more automated, that we connect them. So thank you.
Thank you.